Hi, it's Dr. Riley Clark again from the Whitecap Institute in Heber City, Utah. Thank you for joining in on this week's topic, the Holy Digital Trinity, oral scan, CT, and bite. I'm excited to talk to you guys about these diagnostic processes that are most important for us being successful with our implant cases, and a special focus on our full arch implant cases. And so if you are getting into this sort of workflow or wanting to get into this workflow, it all begins with this lecture right here. And so these things are fundamental and basic to the success of our cases. And I'm excited to share all this with you. So this is again our workflow. And if you watched my webinar last week, you saw me show this workflow, step 1 through 6. And each of these steps is obviously an important part of the workflow, but step 1, the diagnostic step, that is obviously where the tire meets the road. That is where everything gets started. And so if our diagnostic gathering, if these 3 data sets are not obtained in an accurate, proper way, then step 2 will not be done properly, which will lead to bad surgery, bad prosthetics, and a bad final product. And so really, like I said, what we're talking about is the foundation of thoughtful, predictable workflows that leave you and the patient happy and satisfied. So with that said, in review, this is what we're talking about. On the far left there, we need an intraoral scan. We need scan data that is accurate, that is clear. We need a bite that relates the upper and lower jaw to the proper vertical dimension. And then we need to know the osseous structures found in our CT. And so these are our 3 data sets that we'll be talking about. And without these 3, we really don't have a full picture of what's going on. So just like this picture that I saw the other day on some social media, it reminded me of digital workflows with 3D analysis. If we only have, let's say, one side of the apple to look at, like the CT scan, but not the intraoral scan, we might be blinded by what the other side of the apple looks like. And so it's important that all of these data sets are obtained and accurately referenced to one another so that our case can proceed in a predictable fashion without any surprises, without any hidden corner, just like this apple shows. You guys might have remembered this in the media a few years ago. This picture hit the media outlets and it got really popular in the news. And it had people thinking, what was going on here? What's happening? And then a few minutes later, the real picture hit the news and it showed a different perspective and it helped everyone understand what really was going on. And so what I like about today's topic is that it allows us to be thoughtfully viewing all of the patient's parameters from every vantage point. If we were left with just one of these 2 views on the screen, we wouldn't be perfectly clear with what the diagnostic tools are representing, what the treatment plan should be, and how we should proceed with the case. So having a thoughtful plan from all perspectives is most important. To put that in dental terms, we might be looking at a CT slice and we might plan an implant beautifully within the osseous contours of the ridge. But as we dive into the more thorough picture of the actual patient, we might realize, wow, that implant position relative to bone might be good, but its position relative to occlusion might not be complementary to what we're trying to accomplish. And so all of these data sets and proper reference to each other are key for successful treatment planning, and a successful treatment plan is key for successful treatment outcomes. One other perspective I'd like us to be aware of is that we're dealing with 2 different file types. The CT is a DICOM file, DICOM, DICOM. So the implant is actually planned and positioned relative to the DICOM set. So we will plan implants relative to one file, meaning the CT file or the DICOM. However, the surgical guide is actually planned relative to a different file. So these 2 files need to be properly aligned and oriented relative to each other because the implant position and the guide position needs to be perfectly aligned. And so again, as we approach this data gathering process and these three very important pieces of diagnostics, I want us to understand not just their individual importance in terms of accuracy, but also their collective importance as they build off of each other and complement each other in the treatment planning phase. Because again, the implants are planned in the DICOM world, but the surgical guide is planned in the STL world. So all of this data must be referenced to each other in a thoughtful way. So in dental terms, this is what your DICOM, this is your CT. As we gather this data, it's important that we appreciate what we're looking at. This is representing the bone. The 3D rendering of the bone as seen in the screen here is good, but only serves so that we can understand where the teeth are relative to the bone. So here you're seeing the STL data overlaid or merged with the DICOM data, allowing us to visualize not just the bone, but also the tooth position. So as an overview, once we have these two data sets aligned, then we can add prosthetic teeth that are positioned based on a proper bite record, and only after then are the implants actually planned. So it's kind of a step 1, 2, 3, 4. Get the bone reference, get the tooth reference, merge the data, place prosthetic crowns, and then plan the implants. That's the workflow we want to try to follow. Now, what I love about these diagnostic data sets and the digital workflow is it allows us to be thoughtful with our planning. What makes these data sets so important, it gives us the opportunity to do a rehearsal or a practice run of surgery. And with that rehearsal, we can optimize the surgical plan and we can make fine-tune adjustments on the computer screen so that fine-tune adjustments or even large gross adjustments are not needed within the surgical phase of the clinician in their practice. And so just like on a green, if you had endless putts and you kept getting opportunities to hit a putt until you made it, and then that's the one you stick with, that's what digital workflows represent. And that's what these data sets give us an opportunity to do. So with that said, let me jump in and share some pearls about this data that might help you be more successful in your practice. So these are our pre-operative protocols for our patients for guided surgery, especially full arch. So first is what I call the tooth reference. This is accomplished from an intra-oral scanning device, and that data serves as a purpose of representing where the teeth actually are. Now, one confusion that is out in the industry, in my opinion, is that often clinicians think that if I take my intraoral scanner and scan the patient, whatever data is collected is perfectly accurate. I would disagree. There can be problems that occur. For example, in the images you're seeing here, the buccal and lingual contours of the teeth were not properly aligned, and you can see that when you stare or zoom in on the incisal edge. Do you see that difference between the buccal and the lingual contour? Those differences were not merged properly, and that's actually an inaccurate data set. And so I want you to be aware, just because your computer collects data and creates some type of image on your computer when scanning does not necessarily mean it's accurate. We have to be more thoughtful than just scanning and thinking the computer and the device did it perfectly. Our technique, our approach, and ultimately our approval of the data before we send it on is very, very important. Another pearl I want to share with you, sometimes these things called markers are needed. Markers are a helpful tool when scanning to help provide a more accurate data set when there's a lot of metal artifact used. I'll actually talk about this more a little bit later, but know that when we're scanning and there's excessive metal artifact in the mouth, these markers can be used to create a more clear image so that the laboratory can properly align the two data sets. We'll talk more about this later when we talk about merging. But the pearl is when there's multiple restorations in a quadrant, we might need to use these markers to create a more common piece of data that's not distorted. Now here's a real practical tip when scanning. It's really important that the patient is seated at an upright more angle. I think that's more ergonomically appropriate for you. Use lip retractors, and then I really like scanning always in grayscale, not color. True color is a real popular way of scanning today because I think patients like it, but I do find that for myself, when scanning in grayscale, it's actually more simple for me to find any flaws or errors within my scan data. What you see here in the picture, this yellow line, represents a pattern that I recommend we use. I call it kind of the rainbow technique, going back and forth from buccal to lingual surfaces as we go across the arch. And so getting really accurate scan data, in my opinion, is all about technique and about your approach to gathering the data. If you realize that this data is essential for proper surgical outcomes, then the data is often acquired with a little bit more thought, and with more thought turns out more important. So a perfectly placed implant starts with a perfectly scanned arch. And so everything starts here. Don't delegate this to an employee or a new hire who isn't skilled in this. They need to be very, very talented to do this properly. Now, more topic on that rainbow, you might have used some of these other different techniques for your scanning. I personally used to do a lot of scanning shown in the top left, option A. And I used to like that because it was very efficient and easy. But actually, through some studies, we've learned that option D, again, the rainbow type effect, is actually the most accurate data. And so here you're seeing some of the accuracy from the different scanning types. And this option in option D represents the most accurate data from scanning. And that, again, is following this rainbow buccal to lingual. Will help minimize distortion and create a more accurate data. So how we scan, the pattern we follow even makes a difference, believe it or not. Some other distortion errors that can happen is if we just don't get enough data. Sometimes maybe the data wasn't clear enough and it will actually cut off distal extensions of your data. That would be a problem because we need to see not just the dentate areas, but obviously the edentulous areas, because that's where the implants are going. Another issue that happens is this scan distortion because not enough data was seen by the scanner. Now that can be visible either on incisal edges, interproximal areas. So it's important that once the data is refined, that you take a minute and evaluate it closely, zooming in and looking at it. And if you see on these images on the left, I find the grayscale up on the top is actually the easiest to see. The color version is sometimes a more difficult scan to really appreciate. The other thing I want to mention is capturing a proper bite. As you know, with our full arch workflows, we're not just planning implants, but we're also planning prosthetics. So to get the implants in the right position relative to bone and teeth, that's important, but also important is that the teeth fit over the implants in the proper occlusion. And that's accomplished by getting the proper bite. And so again, you need to check the data, you need to inspect it before you release the patient. Don't just get the data and then let the patient go. You have to analyze and evaluate the data before the patient leaves your office. And so that's my recommendations with intraoral scanning. The one other option I will talk about is the edentulous patient. Patients that are already edentulous, which I think is a great way to start with your full arch cases, is your current denture patients. We're going to use a special scan for these patients, and that is scanning their actual denture. I'd like to play this video and I'll narrate through it. This video can also be found on order.dionavi.com. There's more videos there that talk about different references. So essentially, you're going to start with the patient's own denture. The denture cannot have metal in it of any kind. You need markers, your intraoral scanner, and some impression material. The first thing you're going to do is do a reline impression. So this reline impression will be done, and then the markers are attached in the anterior and then both distal quadrants. So this is where you want to get with the patient. Now, after that process is done, you will scan the actual denture as shown here in the video. This scanning can sometimes be difficult at first. Take your time. This is done outside the mouth, obviously. But with proper training and practice, this can be done routinely, this entire process, in probably 10 to 15 minutes. Notice the pattern again as it goes from the intaglio surface up to the markers. So there it is. So here you're seeing a complete denture scan, and then in the grayscale, you can evaluate it and see if there's any areas that need a little bit of fine-tune adjustment. So see, the markers were not captured perfectly. You can go back and capture that data. And then all of the data can be really beautifully captured. So that scan will be used for your edentulous patients. Anyone that has a denture will come in and you will scan those patients with those markers and with the proper reline material. And then that data is then taken to the CT, and a CT is taken of the patient wearing that denture. So that is your protocol for your edentulous patient. Now, let's talk more about your CT itself and capturing that CT data. Here's a few general recommendations. Number one, I recommend at least an 8x8 field of view. If you have anything a lot smaller than an 8x8, you might not capture all the proper anatomy to actually evaluate the sinus, the nerve, all of the anatomy that's important. So an 8x8 is my minimum size that I recommend. And then you need to make sure it's what I call a clean scan. Let me talk about that. Not all scans are created equal, meaning sometimes you might get patient movement, you might position the patient in the wrong way or capture the wrong field of view. As you see on the far right, if you ever see these ghost type images, that is often caused by patient movement. You'll get the duplicated images of the teeth. If that ever happens, you'll need to retake your scan. If you ever open up the scan and notice that part of the jaw is missing because the patient was positioned too far forward or back, a new scan will also need to be taken. So the same principle applies. Practically speaking, you need to capture the data. You need to then evaluate the data before you go ahead and release the patient. The data needs to be evaluated. Don't just think because I pushed the button or I took the scan that the data is going to be perfect. It's really important that you evaluate the data and make sure it's accurate so it will meet all the diagnostic requirements. So be careful with that. Open the scan, make sure you take a look at it. Now, what do we do with these data sets? We get the CT, we get the STL file from the intraoral scanner. Now we have to merge it. I want you to see what this merging process looks like to appreciate everything that's involved and how the accuracy of the data makes this easier or harder. So what you're seeing here on the lower left is the CT data. A pre-selected density has been done so that we can view the teeth and not too much scatter. So there you see the density being either included or excluded. Now we have the STL data right here. We're going to find common points of reference, and we're going to add markers saying 1 to 1, 2 to 2, and with that data, we'll be able to align the teeth 1 to 1. Like I talked about, the bone reference and the tooth reference needs to be aligned as well as possible. So we're looking for prominent cusp tips or some type of clinical crown anatomy that is consistent on the two to line it up. And then here you're seeing we're able to look at this data and evaluate its accuracy. Anything in the green is extremely accurate. We want to avoid the blues and the reds. So that was the auto type merge feature, the initial alignment. Now you'll be able to go through it and manually move things around based on slicing through the DICOM slices. So you're seeing the yellow kind of brownish line. That is representing the outline of the impression. And then you're seeing its outline relative to the anatomy. And then fine-tuned movements can be made in this phase to make a more accurate representation of the two data points relative to each other. As you can see, this is done and viewed in the axial slice, the coronal slice, and the sagittal slice. And then once that data is accurate and we're comfortable with it, then we proceed on to planning. So that looks really nice, a good merge right there. Let me show you what it can look like when you're dealing with patients that have a lot of metal in their mouth. So here's a video of this data trying to be merged, and see how messy this data looks. There's a lot of distortion. There's a lot of different data here that's making it more difficult to align everything properly. This is your common implant patient because they typically are heavily restored. So see how messy that data looks? That is not clean data. That's a case that's going to be much more difficult to merge. So even as different anatomy and density is removed, it's hard to identify similar clinical crown anatomy. You see the difficulty there? It is so ambiguous what we're looking at. As you can see, more data points are trying to be found. There we're seeing some incisal edges. Looking for one last one. Okay, so now it overlays it, and look at all of the red color in this merge. So this is a merge that's going to be a more complicated merge because, again, all of that scatter. Now, like I talked about earlier, cases like this where there's a lot of metal scatter in the CT scan, the use of markers would be helpful here to create a more clean data set so it can be merged more thoughtfully. So that might require a lot of initial or manual alignment due to some of the ambiguity of the data set. So here it goes into manual mode, and you'll see how the STL can be manipulated and moved relative to the DICOM to try to make it more accurate. We'll watch this for a second. So you see how it's grabbed, you can move it. There you see a little void area. Now it's moved more forward. It can be rotated, translated, any direction. So that's the merging process. And as these data sets are not clean and easy to interpret, then the alignment of them is also not real clean and accurate. And that creates a less accurate guide, meaning the implants will not be as accurate and that won't fit as well and as graceful. So this is something we want to try to avoid so we can make surgery as predictable as possible. Let me go ahead and jump ahead to the use of markers. So I talked about markers. These are used when we're capturing data for patients that are heavily restored with metal, creating a lot of metal artifact. They are placed on the teeth or on the denture. They are scanned intra-orally or on the denture, as well as a CT taken of them. And the markers provide an ability to interpret the data without all that metal scatter, creating an accuracy for us. So what we're going to do here, you'll see we'll be able to slice through this. And as we slice through this, we'll see more accurate data because now we're not staring at just the teeth. We also have the marker we can look at. So you can see where the clinical crown is. There's a lot of scatter. And then when you see the markers, it's a much more clean picture. So here goes this merging process. You see the scatter coming off of the teeth, and then you see a more perfectly aligned marker right there on top. So instead of trying to match tooth crown to tooth crown, we can now line up marker to marker, which doesn't have nearly the same amount of distortion. On your full arch cases, this is even more important because we're dealing with many implants that need to be parallel one to another. And so this accuracy is super, super important. Okay, so there's the 3 data sets. Now you see a much more thoughtfully aligned set of teeth. And then again, we can go into manual mode and things can be manually adjusted from there. So here's the manual alignment. And again, the manual alignment can now be done, creating small tweaks or changes to make the data more accurate one to each other. So there you're seeing it go through, looking at the cross section, seeing if the STL should be changed in any way to create a more accurate data set. So those are the data sets that are going to matter. In review, there's 3 important data sets to give the lab all of the information they need to create an accurate surgical plan. And that is number 1, an intraoral scan. Number 2, properly aligned in the right VDO. And then number 3 is CT. With all of that data planned, or all of that data obtained, then thoughtful planning can be done. And so this slide right here kind of touches on really the purpose why we do this. All of our digital planning is based on the accuracy and the completeness of the digital files. And so with the digital planning world, we now have, as I like to say, endless putts to try to hit that hole in one. We also then take that good information, go to surgery, and get a predictable outcome like you see here in the bottom right. That right there represents a lot of thoughtful planning from really good, thoughtful data. We have multiple implants in key positions. They are all parallel to each other, and they fit beautifully relative to a prosthetic. That picture on the bottom right is why the data is so important and how powerful it is, because we can accomplish things like this in a matter of minutes instead of hours, because the digital files allow us to expedite this entire process. So again, I'm going to start where I end. Our workflow today for full arch is really, really compelling. It is efficient, it is powerful, but it has to start with proper diagnostic data. So as you tackle your next cases, I invite you to be extra thoughtful with the intraoral scan you obtain, the CT you obtain, and the bite you obtain. I want you to look at it and evaluate it for accuracy and completeness before you move on with your digital planning, because if you're planning off of poor data, you will have poor outcomes. I hope that was helpful. I really appreciate your time. And I want to thank you for your attention. Good luck out there as you tackle your cases, and be in touch if I can ever help out. Thanks again for tuning in.